I'm Joyce Barnathan, President of the International Center for Journalists. Welcome to our Global Health Crisis Reporting Forum. A few housekeeping matters. If you're on Facebook, search for the ICFJ Global Health Crisis Reporting Group. If you are not on Facebook, please go to our COVID-19 resource page on icfj.org, where you can sign up for newsletters and register for upcoming webinars. It is my pleasure today to speak with Dr. Anders Tegnell, the state epidemiologist of the Public Health Agency of Sweden. As many of you know, Sweden has taken a different approach to combating the novel coronavirus. While there are some restrictions, such as voluntary social distancing and no gatherings larger than 50 people and others, the general approach has been far less severe than a complete shutdown of the economy. People in Sweden are going to work and to restaurants, spaced out, and young children are going to school. As the rest of the world reopens for business, however gradually, everyone's taking a look at Sweden to see if there are lessons to be learned. And I must add that the Swedish public places an extremely high level of trust in Dr. Tegnell and the Public Health Agency, which is calling the shots instead of the politicians. Dr. Tegnell, nearly 3,000 journalists have signed up for our forum, and I know there are hundreds listening today as you explain your country's novel approach, both the rewards and the risks. Journalists listening on Zoom, please type your questions using the chat icon below, and I'll do my best to ask them. And those of you on Facebook can write your questions below the video post. I have to add that I've gotten many questions ahead of time, and I've already incorporated many of them, even from Sweden, that were sent in prior to the discussions. And finally, this webinar will be recorded, and you can find it on ICFJ's YouTube channel. So let's begin. Dr. Tegnell, explain briefly the reasons why Sweden didn't go into lockdown mode the way other countries did. What made Sweden different?
I think we started out using the methods that we always use in public health, having sort of a conversation with the public, putting a lot of trust in the public and giving a lot of responsibility to the individuals, which is exactly what our communicable disease laws are telling us to do. And by following that pattern, and also that we could, doing this, we could keep the number of cases down and we could keep our health services working. We were never under great pressure to move into something different. And instead, we did a number of smaller things, like you have been alluding to. Like we said, okay, we want to have bigger congregations than first 550 people. We also looked at the restaurants, which we knew from Italy and Austria and other places were places of great transmission, and we tried to minimize the transmission in those places. So in general, we said we don't want to lock down the whole thing. We want to sort of close down and minimize the transmission in areas where we know that there's a high risk of transmission, realizing that this will not stop all transmission, but putting it on a level so our healthcare could cope with it.
Well, that's interesting. You know, I come from New York City, and there were very few cases at one point, and then it just exploded and did, to a large degree, overwhelm the healthcare system. Why didn't it overwhelm the Swedish healthcare system?
It's a bit difficult to know, but my impression is still that we were very much alert. So we really saw cases very early on. I think in a few other countries where they were overwhelmed, it was partly because they didn't see the slow beginning of this epidemic, but rather only noticed it when there was already so many cases around that they couldn't stop. And this was probably due to testing too little in a number of places.
So you were testing very early?
We were testing a lot very early on because we saw the epidemic coming with our spring vacation travelers. I think that was the big introduction into Sweden. We have a spring vacation different weeks in different parts of Sweden. And Stockholm, who is the really epicenter of the epidemic in Sweden, had a spring vacation at the same time that there were huge outbreaks in Central Europe and other places of the world. And a lot of people are traveling, a lot of people came back with the disease, and we tested lots and lots of them.
I see. Well, I know we have to talk about the deaths in Sweden because they are relatively high compared to your Nordic neighbors. I took a look yesterday just at the stats, and there were more than 3,000 deaths in Sweden compared to 217 in Norway and 255 in Finland, which is a big discrepancy. And even Denmark had 6 times fewer deaths. And you know, as I looked at the numbers, it still looked like the cases in Sweden were rising. Maybe you can correct me on that, but yesterday it looked like there were 705 new cases with 99 people dying. Yesterday, where Norway, there were 19 cases and 1 death. So I'm just wondering, do these high rates concern you, and why isn't it ticking downward?
Yeah, that concerns us very much. I mean, this is a terrible experience for any country to have so many people dying. And we looked very, very closely at it, and we found that the big explanation behind it was really a lot of deaths in our elderly homes. And these are elderly homes in Sweden, which are not just for any kind of older people. These are for the people who are really ill and very old. So about 70,000 people in Sweden live in these homes, and these are the 70,000 people of the Swedish population who are definitely the oldest and the sickest of them. So these are, of course, also the people where if you get the disease into those kind of homes, you will have a big death toll. And unfortunately, we had a big introduction into those homes, especially in the Stockholm area. And that accounts for more than 50% of all the deaths that we experience in Sweden.
Yeah, I think it's similar in a lot of countries here too, where the high death rates are coming from old age homes or senior facilities. Are you telling me that you weren't that the old age facilities in Sweden weren't properly prepared for this crisis? That if you had to do it over again, you would do something very different there?
Yeah, I think we have known for a long time that the quality of care in those facilities has not always been up to standard, especially in the area of hygiene procedures. And there has been a number of investigations telling us that no, the level is not high enough. And we also know that we get spread of antibiotic resistance and so on in those facilities. So they were known to be a weak part. And I mean, there's a number of different agencies involved in this, and I don't want to point fingers to any specific ones. But yes, I mean, in retrospect, you have to say that these facilities were not prepared to do this in a good manner. Now, when we started looking at them, we can see already, just by looking at them, that the numbers are actually slowly going down. The number of cases in those are slowly coming down, especially in the Stockholm area. And actually, our death toll is falling, slowly but falling.
In the old age homes, but not in the country overall, is that right?
In the country overall also. It's a bit complicated because the death rates are reported in with some delay, which means that we have to do some specific statistics analysis of them. But we can, and we know that the rates are stable if we go like 10 days back. And if we look 10 days back and we look for another 10 days back, we have fallen from 90 cases a day to 70 cases a day in that period. And it looks on our statistics that the fall on the number of cases per day will continue in the same manner.
Well, I'm curious because as your neighbors and Nordic neighbors begin to open up their economies, is the thought that they'll be experiencing higher death rates? In other words, the cost of shutting down the economy doesn't lead to more lives saved. Is that what we're saying here?
I think we don't know. But we are just doing some zero epidemiology in the Nordic countries, in all of them actually, and we are now getting results from several countries showing that our Nordic neighbors, maybe 1% to 2% of the population are now immune, while the estimates for Sweden is around 25%. So of course we are much further into this epidemic and much closer to having a level of immunity in the population that will help us very clearly to keep a low number of cases every day while having a very open society. Well, if this is translated into death tolls exactly remains to be seen. But I mean, the Swedish healthcare system has always been working very well. There is no reason to believe that this death toll is due to that the level of hospital care was in any way less than it could have been.
Yeah, I find that fascinating that the hospitals were not overwhelmed. I've seen that you've said that there still are ICU units that are available. Are you saying that there are beds and there also is the staff to take care of those beds should they need to be filled?
Yes. The National Board of Health and Welfare who takes care of this, they say that there has been no time during this pandemic in Sweden where we had less than 20% of the beds free. And then beds are really beds. There are beds with staff, facilities, everything in place.
Okay, so fully staffed facilities for 20.
Yeah, yes.
Okay, well, you mentioned the herd immunity idea, and I want to follow up on that. You said what, 25% of the population now has immunity. So is this the idea, without a vaccine, is the goal to allow for a broader exposure to the virus as a means of protection?
Not really. Our goal has always been to keep the level of spread down low enough for our health system and for our society as a whole to keep on functioning at a good level. And I think we have managed to do that in Sweden. With, of course, the very sad exception of the high death toll we have, but that's a little bit different issue in this. But then, of course, we also know that eventually we will get a help from the immunity in the population to keep the level of spread down. And in the long term, only a level of immunity in the population will keep the spread down to a reasonable level until we have a vaccine, which is going to be quite far off, as at least what I would think.
Yeah, I'll follow up on that in a minute, but let me stick with the herd immunity. Scientists here, and I've been listening and watching and reading, seem to be fairly uncertain about the level of immunity people who have contracted the virus may have. Are you confident that there is immunity and that it will last for a certain period of time? I think here there's a big debate about, they don't know. So there are big questions about, all right, even if you are immune, can you how long does it last? 2 months, 3 months, 6 months? Even if there is a degree of uncertainty about whether there is the immunity, maybe you can catch it again.
Yeah, I know that immunity is a tricky question for this disease because, normally you measure immunity by the number of antibodies you can find in the blood, and the level of antibodies among different cases seems to vary a lot. So it's going to be a bit tricky on the individual level to estimate if somebody is immune as a person or not. Our virologists and immunologists are there, on the other hand, quite certain that immunity does exist. And I think there is a lot of proof of that. For all the cases we have had in Sweden, there has not been one single person who had this disease twice. And we have a very strict identification system, so there is no way we would have missed a person who had it twice. And I haven't heard any reports from many countries where there has been a certified case who has actually had this twice. There's been rumors about it, but in the end they have been disclaimed. So I think that's not the problem. The problem is to say if an individual will be immune so that you can tell this person you will never have this disease again. And that's where we still don't know because we don't have long enough observation periods. We are not quite ready yet to say what level of antibodies is protective. And maybe there are other parts of the immune system that provides protection that antibodies will not do. And for how long this immunity will last, our virologists said that at least 3 to 6 months, they would say as a minimum. But nobody knows because we haven't observed this for very long yet.
So at what point do you think you'll understand the issue of immunity?
That's a tricky one. I think the way we look at it, we think that the now slow decline of the number of cases in Stockholm is due to a level of immunity in the population. Because we do see a drop of cases and we haven't really changed any measures for the last 4 or 5 weeks. And if anything, there is slight signs that adherence to social distance and so on is maybe a little bit less now than it used to be a few weeks back. So the one reason we can see for this slow decline of cases really is that there must be enough immune people in the population to keep the spread down a bit.
So what's your opinion of those countries that instead of aspiring or hoping for some high level of herd immunity have, locked down and opted to gradually open, test, track, and treat for the disease? Is this also part of your strategy to test? The testing is part of your strategy. And what do you think of this? What do you think of this alternative, which is ready to lock down and then gradually open up by testing, tracking, and treating?
Yeah, I think these countries are thinking about the same thing, that they want to have a slow spread of the disease. And I think the lockdown, at least in some countries, was due to a very rapid increase of cases. And then this sort of softer measures might not have stopped that. And now, when they've stopped the really big spread, maybe a level of softer measures can keep the level of new cases down on a level. If this thing about testing a lot, contact tracing and so on would really make this possible, that remains to be seen. I mean, we're talking about a huge undertaking. In a country like Denmark, I just heard Denmark with 3-4 million people, they are going to employ 18,000 people just to do the tracking. And that does not account for all the testing personnel and so on. So this is a huge investment by society to do something. We are not quite sure about how well it's going to work because it is a tricky disease. It does not always show with very good signs. And that means that this normal testing and tracing strategy, which works much better with diseases like measles and very clear diseases like that, how well it will work for this kind of disease, we don't really know yet.
So as we look at these various options, it'll take time for us to figure out who really got it right, correct?
Yes, that's for sure.
Okay, let me ask you something about why the Swedes are not wearing cotton masks that you can easily pick up online. Health authorities in the US and Asia say this is a real aid in not spreading the virus. And I'm not talking about surgical masks that the hospitals need, So why aren't you recommending that the Swedes do the same?
I think for two reasons. The first reason is that the science behind this is not very strong. I think everybody I talked to points back to one study from Hong Kong, a very theoretical study where they've studied how droplets pass through cotton masks and so on, droplets containing different kinds of viruses, not COVID-19, but similar kind of viruses. So it might be true, but it's one small study. It's never shown that it's going to work out in public. And if this really is going to have an effect on you not infecting somebody else is, to us, still very unclear. To that, you can add that in Sweden, one of our strong policies has been to, if you feel the least bit sick in the morning, stay home. And we are afraid if we start introducing masks, people will, instead of staying home, they will put on a mask and go to work, go out and shop and so on. And that will definitely be a lot more spread around those people than people staying home and isolating themselves. Furthermore, our government has made it possible to stay home for the first day because you get your sick pay from the first day from the government these days. So there is no financial incentive to go away to work. You can safely stay home and you will keep on getting the same kind of money.
Yeah, I think that may be a difference in Sweden and other countries where people feel they still have to get up and go to work and they don't have a government that's backing them and paying them to stay home.
Yeah, I think there is a number of reasons behind a lot of the measures we take and why they are different in different countries, because we do institute these measures in different contexts, and we need to realize that the context can be very important.
Right. But you also said not to make too much of the differences either, so we have to look at them. But yeah, okay, let me ask you about schools. Because right now, many children in the United States are not attending school, and elsewhere around the world. I see that in Sweden, high school and college students are staying home. And I wanted to ask you about your decision, why older children are not attending schools, and what's your evidence that young children are not carriers of the disease if they do go to school, because people are worried about that here.
The reason why we said that high schools and universities should go to distance learning is twofold. One, that we know that distance learning works quite well in that context. It's used quite a lot at universities and to a certain extent already in high schools. So they will still get their education and the system will still work. But on the other hand, they travel quite a lot, especially in universities, but also in high schools. You tend to sometimes travel quite long distances between your home and the high school. And since we have the spread in Sweden is very uneven geographically, and Stockholm is really the epicenter, we really do not want to have too much travel, because I think that's one of the important parts of the Swedish strategy is to limit travel and geographic spread of the disease, so that we don't have a lot of spread in the whole country at the same time. So that's the reason behind we pointed to the older children in closing down. When it comes to younger children, I think the evidence also needs to be taken from the other part. What evidence do we have that younger children actually is the motor of this pandemic or not? And there is no such evidence whatsoever. We see extremely few cases among young children. Among the 16,000 cases in Sweden, only 200 were among people less than 20 years of age. So we don't see much disease in those age groups. And then people say, okay, children still have the disease, but don't get very sick. Yes, that's true. Children do have the virus now and then, but there is very little evidence that they spread virus from children to adults. The Icelandic people are very well controlled. They have looked very much at this. They have seen very limited spread from children to adults, and they have a very good system for that. We know of cases in Finland and Sweden in schools. We have seen no spread around them. The one spread we have seen in school are between teachers coming to work with symptoms and then infecting other teachers, like you would see in any kind of working place. And during these 3 months, we cannot connect anything of the spread in Sweden to the schools. And I think what we now see in many parts of Europe is what they do is they open up the schools first. So I think this whole theory of the schools being the big epicenter of the spread comes very much from flu. And flu is a very different kind of disease. There we know that the children are very important in the epidemiology of the disease. For COVID-19, there is no such evidence whatsoever.
So you feel that you've got scientific facts to back up the fact that this is the case?
As much scientific facts as there is about anything with this disease. We have to realize that almost all decisions taken anywhere in the world are not backed by solid scientific evidence, because there's not been so many studies about this disease. There is definitely no scientific evidence around lockdowns. There's no scientific evidence about closing borders. And even for flu, there is not very strong evidence that school closures really makes a difference in the long run.
When you look at the evidence that you do have now about children, what ages are you looking at to cap going to school? Is there, because there are teenagers, there are 3-year-olds, there are 4-year-olds, 5-year-olds. So is it all children under a certain age that you feel are not carrying the disease?
Yeah, we don't see anything in children at all, I would say, up to the age of 18.
18?
Yeah.
Oh, wow. That's pretty interesting. I have a question from Sweden. We're being told here in Sweden that sending our kids to kindergarten and schools is safe and in fact good for them. At the same time, all private schools and kindergartens where the elites are sending their kids remain closed. Why doesn't the Public Health Agency respond to this? If being in school and kindergarten is good for the kids' health, are privately educated kids' health in danger?
That's a tricky question. First of all, we don't regulate schools. That's the Minister of Education who does that, and it's the Minister of Education who possibly could close schools, but and really it's a local matter. It's the local authorities who could close schools. So we don't have any authority neither to close nor open schools. On the other hand, there is in Sweden, there is a law saying that children have a right to be at school. And I know that private schools have somehow managed to get around this sometimes, but I think that was mostly in the very beginning. Most of them are now having the kids coming back to school. So I mean, this is not a matter of rich and poor. This is a matter of that part of the Swedish schooling system, especially in the big cities, have become private. And I think we're still fighting a little bit about in the Swedish system how we should control these private schools better to having them more following the national guidelines in different manners, not only in this one.
You know, in the rest of the world, there is this fear factor of contracting the virus. So even if economies are opening up, they don't feel comfortable returning to their pre-COVID-19 lives. And I'm curious why the Swedes aren't fearful.
I think a lockdown will put fear into anybody. I mean, it's very difficult in a communication manner first to tell people we need to lock down complete society because this is such a dangerous disease that we cannot keep anything open. And then 4 or 6 weeks later saying, oh, there is no worry anymore. Now you can all go back and live a normal life. And I think that's part of the reason why we believe in the Swedish strategy, because it is really a long-term strategy. It's sustainable over a long, long time. And we know that we're going to have to sustain it over a long time. If we get a working vaccine sometime, we are still talking at least a year, maybe a year and a half, maybe even longer before it becomes in place. So when we go out and ask the Swedish population what their fears about, they are fearing about their economy. They are fearing about losing their job and these kind of things. And only like 5-10% of them fear the epidemic.
Minorities in the US are contracting the virus at higher rates, mainly because many are essential workers who have to leave their homes to do their jobs, whether it's driving a bus, delivering packages, whatever. And this puts them into greater contact with the wider public, so they're contracting the disease at higher rates and dying at higher rates. I have a question from Greta Gober, a postdoc fellow in global media studies at Stockholm University. And this is what she says. This is her quote. COVID-19 has disproportionately affected migrant and minority ethnic communities, but the health agency has not changed its recommendations to take into consideration the socioeconomic differences in the society. So are you finding that minority and guest workers have a higher rate of contracting the disease in Sweden, and are you doing anything to address that?
We don't have guest workers in Sweden.
Oh, sorry, I had a guest, but okay.
Yeah, but anyway, yeah, we know that some of our people born in other countries do have a higher level of risk contracting the disease, and we can see, especially in our Somali communities, to a certain extent in our Syrian community, they are affected worse, especially in the very beginning. That was true. It's getting more and more equal. And I think there's a number of reasons behind that. Socioeconomic reasons are definitely there. More contacts with the rest of the world, living very close together and sharing living quarters between different generations, because even in those communities, it's of course the elderly who really get sick, not the young and the middle-aged. So there's a number of reasons of this. And we saw it very much in the beginning. As I said, it has been leveling out a lot more over time. So one of the things that happened in Sweden, that this disease came into those communities very early on and then spread in those communities, unfortunately, very much before the communities or anybody was really aware of this, because this was very early on. We're now talking February, a little bit into March, when we did not really see very much of the disease in Sweden. We have worked very much with the regions and communities and so on to reach these populations and in different ways try to address, giving them advice, seeing to it that they can get access to healthcare in different ways and so on. So I think we have really worked to reach these populations, and we also have a long tradition in reaching this population, because we have reached them in messages around vaccinations and other things. So yes, I mean, we do have a problem with integration in Sweden, and that's of course part of the reason why we have this problem that we have, that these groups have a lower socioeconomic status than many Swedes and so on, and then gets more affected than others. I mean, to me, the main reason behind this is the social economy and those kind. We are looking a bit further into that because we have a lot of data on social economy and so on, and we can probably come back with better understanding of why this community was so affected, especially in the beginning, when we get a bit further into our analysis. But it is, once again, just like with elderly, very unfortunate, and something, I think this was more something we did not really foresee, that this group seemed to have had a lot of contacts abroad, and the disease came into these groups much earlier than it did in other parts of the Swedish population.
Let's talk about the elderly a little bit. First of all, what do you define as elderly? What age is elderly? What is the age of the most vulnerable populations?
We have done it like this, that we have said we had a cutoff of 70 right now. Not because we really know that that's a big turning point, becoming more or less vulnerable, but because it's an age that fits into the Swedish system. Most people retire around 65. These days, many people work a few years more. If we have a cutoff at 70, we get the population that's mostly in retirement, which makes a lot of the measures we ask them to do a lot easier. Then a lot of them are quite healthy and probably not very much into risk groups. And we are right now looking at because this is what we did early on, but we didn't really know how this would affect the Swedish population per se. So now we're doing some analysis from our cases to sort of see where is the cutoff in Sweden, and how much does the cutoff depend on if you have other chronic diseases, because we know that the risk is not just connected to age, even if that's the most important factor, but it's also connected to age and other chronic diseases. So we try to find a way to tell at least part of this population above 70 in Sweden that their risk is not much greater than the rest of the population.
So what recommendations do you have for them? What does the future look like for people in that age category? They simply stay home until there's a vaccine, or what is the advice for them? Because I think elderly people might feel a little bit more nervous about being in Sweden than being in a lockdown country.
I mean, our main advice to them is to minimize their social contacts, because that's necessary. As long as we don't have any vaccine or any way of protecting them, the one way for them to protect themselves and protect the health system is really to not have too many contacts with other people. We tell them that it's of course fine to be outside. Being outside and keeping a proper distance to other people, you can also meet people outside as long as you're not too close to each other. But you should not go into crowded area. You should see to it that you can get some help for shopping and these kind of things where you need to get into crowded areas and so on. And then for the elderly people's homes, we have even been stronger and said there is now a law saying that you're not allowed to visit people living in the elderly homes and so on. But mainly the message is to the elderly population to have as few contacts as possible right now. And then, I mean, what we are now trying to do is then try to look at, okay, maybe it's not all of the people over 70, but we might minimize that group slightly. And then as the spread in the society goes down, of course, we can also look at this in a different manner. And the third thing we might hopefully be doing one day is to see what part of the elderly actually already have the disease and are immune, so that we can say, okay, we have measured your level of immunity. We believe that your risk of catching disease is now minimal, so we believe that you can go back to normal life. But those those tests are a little bit further down the line. But I think the test will definitely be long before we see a vaccine.
Well, let's talk about therapeutic treatments in the near future. What looks most promising to you?
We are not following that area very much, I must say. Unfortunately, we don't really see any, at least from what I've seen, we don't really see any hopeful treatment. That there is no sort of silver bullet that's going to make this very, very different. And I think we have to be quite cautious about that, because we know that the population we're now talking about, with most of the death toll, are a population that might be very difficult to save even with a treatment in place, because viral diseases are tricky. You need to come in with a treatment very, very early on. In most cases, even before you have symptoms, to have a really good effect of them. And anything like that, we don't really see. I mean, Sweden is taking part of some of these trials with remdesivir and these kind of things, and we'll see. But the results so far are not that incredibly good that you will say that we have something in place within weeks or months. We probably, unfortunately, talking much longer into the future before we have something really good in place.
Yeah. Well, there's been a lot made of remdesivir here, but not as a silver bullet, more as a way of shortening the length of the disease from 15 days to 11 days. And there certainly was a lot of talk at the beginning about hydrochloroquine, but that doesn't seem to have tested that well. Or, some people say it's not tested early enough in people, so it's still up in the air. What are your assessments?
I think from what I heard from our Meta Products Agency, they don't believe in hydrochloroquine at all.
Right.
They believe that the side effects are far bigger than any maybe positive effects, which seems to be very, very low level of remdesivir. Might prove something, as you said, because the length of needed treatment, especially length of stay in ICUs and so on, is really a big problem, because the length of stay in ICU puts a big burden on the health system, but also puts a big burden on the patients, because having been in ICU for 3-4 weeks sometimes means that your rehabilitation, recuperation time will be very long after that, and it will take a long time for people to come back to normal life again.
I have a question from Belgium. Basically, this person says there's an epidemiologist who has worked in the Karolinska Institute, who has issued warnings to you about the coronavirus, that the strategy is going to end in complete disaster. This person cites a woman named Nele Brusselaars. Have you heard of her, and is her fear justified or not?
No, there's been a small number of different scientists who had the different stages already from March and onwards claim that the Swedish health system will be overwhelmed. We will have tens of thousands of deaths within weeks and so on. Different projections that none of them have come through. We have quite a lot of scientists that we work together with who are much closer to what we believe in is a possible future and so on. So, but this is the way it often is in academia. You have a number of different scientists stating different kind of facts, and I think that's true in many countries of the world right now, that there's a number of different opinions. But I must say most of the modeling and other things that I've seen done about Sweden, which has been done in the States, been done in the UK and so on, has proven very wrong, even before it's published, that it's overstated the number of cases and deaths in Sweden by tens and hundreds of times and so on.
When you look around the world and the data that you see now, and I know it's still early days for us to figure out who's getting it right, are there countries that seem to be, other countries and other methods that seem to be getting it right? I guess what I'm looking for is low death rates without economic collapse.
Yeah, I mean, I'm not that much in understanding of economic collapse, but I think what all countries see when they do the complete lockdowns, that the costs are enormous. Exactly how big they are, I think it's the same with them. We don't know how big those costs are, because many of those costs come in the future. with people being out of work and companies going bankrupt and so on, those effects will be seen for many years ahead. We know that people out of work suffer a lot of ill health consequences, also from a perspective of public health. A bad economy is something very bad for the state of public health. Strong economies, strong health systems will most likely work better with this. I mean, Germany seems to be handling this reasonably well in many ways, but what the economy will do in the long run, we don't really know. And we also need to understand that these complete lockdowns has had a big effect. It actually stopped the epidemic in many countries. In countries like Austria and others, Finland among them, they are now having maybe 1% of the population who had the disease, which means that they have 99% of the population who are susceptible to the disease. And how to handle that over time is going to prove, I think, difficult, and what kind of measures you need to have in place not to see big waves of new cases coming again. We don't really know yet, and now a lot of experiments are going around in Europe in different ways to try to figure out which is the best way to do it.
Is there anything you would have done differently? Besides,
no, I mean,
the healthcare system for the elderly, you said you would definitely.
Yeah, the healthcare system for the elderly definitely. We know that the supply chain into the hospitals should have been much stronger. It has worked. The hospitals have all the time have had sufficient protective equipment and drugs and so on, but it's always been a struggle from day to day to get enough equipment and drugs and so on into place. It would have been much better with a stronger system to supply them. So there is, and I'm sure we're going to find more things when we look back, but I think those are the two big lessons we have learned so far.
Mm-hmm. And you mentioned the vaccine earlier. We're hearing all sorts of dates, some of them which sound ridiculously quick for a vaccine. So I just wonder, what is your time frame for a vaccine? And are you worried that this rush to get one out quickly may lead to a vaccine with major side effects? I know you've dealt with that in the past, so I'm just curious about that.
Yeah, no, we're not doing we're doing some vaccine development in Sweden in academia, but on the very early stages. So, Sweden is not a big producer of vaccines or anything like that. So we don't really have any prime knowledge here in Sweden. From what I hear from people in countries who have vaccine capacity and so on, we're talking at least 12 to 18 months before there will be large amount of vaccines. We must realize here we're talking enormous amounts of vaccine because we might have to vaccinate major part of the population on the earth. And this is more vaccines than we ever had anywhere before. So we're talking huge amount of production capacity. Then developing a vaccine will probably be feasible. There's a lot of things going on, some of them still in very early stages, we have to realize, and of everything in early stages in pharmaceutical, most things goes wrong, we know that. So we have to be careful about saying that this and this will be a good one. And we don't know. This is tricky. Viral vaccines sometimes works very well, like measles vaccines, but sometimes have a hard time creating immunity if you look at the flu vaccines. So it's difficult to know where this disease will end up, probably somewhere in between there. But we have to be careful. And I think you need to realize that when you're going to vaccinate a lot of people, and most of them will not have a very dangerous disease, the level of safety of the vaccine will be a very important part of it. We're not talking Ebola vaccine here with a disease that kills maybe 40-50% of the people contracting it. We're talking about a disease where 99.9% of a young healthy population will not die. And that, I think, puts completely different demands on the vaccine and the safety of the vaccine that we are coming out with.
That makes sense. I'm going to go to questions that have been coming in. I'm sorry I haven't been able to integrate them into the themes that I've had here, but somebody asks here, is the feeling that by staying open and letting people get or exposed at a low level, that Sweden hopes to avoid a second wave of infection?
Yeah, I mean, that's part of the reason, and that's part of the reason why we focus sustainability, because if there is enough people immune in the population, I mean, the second wave that is probable that we're going to get after the summer will be much smaller than in countries who have had very few people being exposed. And especially the demand for countermeasures in different ways will also be much, much less.
How are you preparing for that second wave?
Not too much right now. I mean, right now we're more or less trying to survive from day to day, I would say.
Right.
But we are looking at it now because as many countries, we are starting to look at some kind of exit strategy also from the Swedish measures. And of course, in that will include what do we do to find out that there's a second wave going on very early on, and then discussing, okay, from our experience so far, which are the most important things to put back.
Dr. Tegnell, I don't know if you could hear me, but we can't hear you right now. Let me just see if he comes back in. Oh, we may have lost the good doctor. We did have a lot of other questions that I did want to ask. I'll wait one more minute to see if he can get back in. Okay, well, it doesn't look that promising, but I do want to thank him a lot for sharing his insights at this really important time. And I want to tell all of you that we at the International Center for Journalists are doing our best to link reporters around the globe with leading experts like Dr. Tegnell to ensure that the public gets reliable information that really is a matter of life or death. And his insights were particularly valuable right now when many countries are first opening their economies. Let me remind the journalists who are tuning in to please fill out the survey we send you after the webinar. It helps us design our webinars and improve them, and your feedback is incredibly important to us. So thank you again for tuning in, and I'm sorry we lost him and I couldn't ask all of your questions. Oh, there he is. I've already signed off. Oh my goodness. Okay, are you there? Okay.
So
I already signed off, but I'm signing back on. I thanked everybody, and you.
Okay.
But I have a few more questions, if that's okay, from the audience.
Yeah.
I have a question from a woman named Nancy that said, did you face any challenges inside prisons or closed institutions?
Not very much of that, really. Not from prisons. There's been a few cases around, but no major outbreaks. Of course, the elderly homes are kind of closed institutions, so they would definitely qualify. But apart from that, no, not really.
Another question from Umana, who says, my question is to what extent you believe that the lower number of visitors from abroad, either for business or tourism, compared with London or Rome or Milan or New York City, is the reason behind the lower number of coronavirus cases in Sweden?
Not very much. I mean, I think in all countries these days, the travel does not matter anymore. Once you have such a big spread in the community, the occasional people coming in from travel will not have any importance anymore. Early on, travel was a very big issue in Sweden, but not so much for people coming here, but for people being abroad, coming back home with the disease. And I think that I share that experience with our Nordic neighbors. It's not the visitors who take the disease to a country. It's the country's own citizens coming back from other countries that bring the disease home.
Interesting. Ann asks, do you offer any advice to people under 70 who might be vulnerable because of pre-existing conditions? I'm assuming you want to treat them the same way you treat people 70 and up, but you answer that question.
Yeah, no, we do that. There is some concern about because the systems that not really allow them to stay home with full benefits and so on. So we have some discussions with the governments about making it possible for them to stay home a bit more. On the other hand, it doesn't look like people with chronic diseases below the age of 70 really have a high risk, except in very grave disease, very grave cancer disease and so on. But in general, age is really the most important risk factors, and chronic diseases come second, but quite far behind.
Are there any chronic diseases that you worry about in particular? Diabetes?
Not really. We are looking at that right now, but none of them are really becoming very strong. I mean, the really strong thing is age.
I have a question from Gautama Mehta, who asks, in what ways has the Swedish response been hampered by fake news or the spread of misinformation?
Not very much, I would say. That's partly because I think the high level of trust between the population and the government and agencies and so on. We do monitor social media quite a lot, and we know there's a lot of rumors and stuff going on there, but it does not really affect the major part of the population. I mean, when we go out and ask the population at large if they trust in government, if they feel that they are well informed and so on, we get very high levels of people saying more than 90% of the people feel that they are well informed, and as I said, very few of the population claim that they are very much scared of the disease. Yeah,
that high level of trust in the government is an interesting factor in your country, because it doesn't exist in all countries. From Paolo Pasquariello, my question is whether there is any plan to improve the frequency and quality of official reporting of coronavirus outcome data in Sweden. Data are not updated in real time and are plagued by severe weekly seasonality, which he says is very poor on the weekends, leading to jumps afterwards. And the number of tested, recovered, and dead patients is often updated with delay or not at all. Data is crucial to the access, is crucial to assess the current evolution of this epidemic and to predict its future dynamics.
Well, I'm not really sharing those concerns. We know that with toll, we have some delay. That is definitely so. I would not say that the delays are any worse than in most other countries. I think it's more about that we show the delay very clearly by not just saying reporting date of death. We actually say the date of death. And I think that very few countries do that, more reporting date of death, which I think confuses things even more. When it comes to weekly, that is how that's the real-time data. I mean, there is a very strong regulation in Sweden that anybody who finds a case have to report the case to the authorities within 24 hours, and that happens. But the health system works in that way that many people are admitted, more people are admitted during week times and so on than in weekends. I think that's how any health system works. So this reflects the pressure on the health system. And we do a lot of statistical analysis on that, and it does not really affect any kind of decisions we are taking or anything like that, because we have a very good long history on how to interpret data that comes in this way.
So no problem with the data in Sweden?
For us, no problem whatsoever. We have a very high level of confidence in our data, and since we have this kind of partial identifiers, we can also really test the data, validity of the data very much. We actually have a system of both reporting from the clinician and from the laboratory, which very few countries have, which makes us probably find and collect more cases than almost any other system that we have.
I have a few questions here from people who are asking you to give advice about their respective parts of the world. One gentleman, Hamad Safras, asks, what would your advice be for countries in the developing world, especially those that are inching closer to the peak?
I think that's a matter that really needs to take a lot of thinking, because we know that in the developing world with a lot of poor people, poor health systems and so on, it's a complicated matter to see what you should do, because closing down societies in those areas will really lead to bad consequences for health and many other things. So I think you need to consider a lot more if closing down is really the right thing to do in those countries. On the other hand, you have very weak health systems, so you need really to protect them. On the third hand, you have very young populations, which most likely would lead to less problems with very sick people and so on. So I think you need to be careful in those countries and not take the clue from richer countries in Europe and so on, and think that the measures taken in places like Germany, Austria and so on will work in developing countries, because I think more surely they won't. You need to find your own way using the context you're in to the best of your ability, but be quite careful about these drastic measures of closing down too much.
This is a question from the US, which says that there are concerns about the possibility of the virus being spread by asymptomatic carriers. We talked a little bit about that earlier. Do you have figures for the percentage of asymptomatic carriers in your population? And what risk do they pose to your model?
Let's take the second one first, because that's the easy one. No, they don't pose a risk to our model. Our model works very well anyway, because we are not going for zero transmission. We're going for a control level of low transmission. And then keeping people with symptoms away so they don't infect others will give us enough, will slow the spread down enough for us to achieve that. The level of, I think this is a very complicated thing that's been oversimplified, because in many studies they are talking a lot about asymptomatic people. Many times they mean people with a disease that were not recognized, because we have done some surveys out in the population now testing even asymptomatic people. And when our people come back to the people that actually test positive, saying they have no symptoms to begin with, and you ask them very carefully, quite a lot of them actually had some symptoms. Very mild symptoms, sometimes symptoms developing 1 or 2 days after the sample was taken and so on. So I think that we will have to wait and see, but from our experience, from the experience in hospitals in Sweden, also from the experience from Iceland and so on, I think what we actually see here is a disease which is often very, very mild, maybe not even close to not recognizable. But to say that you have no symptoms of all is not at all that common that we thought in the beginning.
So basically what you're saying is people who maybe just didn't recognize that the symptoms were COVID-19, but they actually had symptoms. Right?
Yeah.
Okay.
Yeah.
I have a question here from Nigeria, which wants to know about the recovery rate in Sweden. Is it higher, lower, and what can people learn about the recovery rate, from the recovery rate?
We have from the ICU, 80% of the people getting into the ICU survives. The death toll for people, and we have admitted some 1,500 into hospitals, into ICUs so far, and 80% of those survived. For other groups or statistics is not clear yet, because we don't follow the map in that way, but we know that more than 50% of the death toll is among people who died in their home or in elderly home and things like that. So the death toll among people coming to hospital is quite low. We also know that the death toll is almost only, I think it's about 85-90% of the death toll is in people above 80 years of age. So recovery rate among younger people is very, very high.
And I think I have one more question, which is from Armenia, who says, from Nareen Macharian, president of the National Press Club. She says, Sweden has been criticized very much in the beginning. And in the beginning of March and mid-April, you optimistically noted that in May, the population will acquire immunity. This is what she says. Today, Sweden is 23rd in the world with its number of infected, with around 25,000 people infected and more than 3,000 deaths. When someone in my country, Armenia, does not follow the requirements imposed here on the quarantine, they mention Sweden. My question is the following. is your experiment successful or not?
No, as we talked about before, yes, it is successful to a certain extent. We managed to have a spread of the disease without overwhelming our health system, which is one of our prime goals. It was a lot less successful in protecting our elderly, and that's something we're working very hard at rectifying right now. And it was successful because people voluntarily isolated themselves very, very much, limited their travel to a higher degree, work from home to a great degree, and so on. So you cannot use the Swedish model to say that you can go out and meet just anybody, and that doesn't matter, because that is not what the Swedish model is proving. The Swedish model is proving that you can get very far by voluntary measures, but you still need to have social distancing in place, and that's most likely the most important thing that you can have if you want to have some kind of control over this pandemic.
Well, I thanked you in your absence, but I'm going to thank you again for sharing your insights. I think they're particularly valuable at this time when everybody's trying to figure out the best way to open up and the safe way to open up and how to get our economies going again, because as you noted, there was a huge price that people pay to close down the economies, at the same time a huge fear factor about contracting the disease. And I think you offered a lot of great insights to all the journalists out there in the world who have tuned in. So I want to thank you very, very much. And I want to remind the journalists to fill out the survey that we sent you after the webinar. And as I said, your feedback is really important to us. Dr. Tegnell, thank you again. And I hope you'll come back in a few months and give us an update on how things are going.
It will be a pleasure.
All right, thank you.
Bye-bye.
Bye.